The skin incision is made just behind the umbilicus, and then the fat was trimmed away, so we can clearly see the linea alba. The muscle is raised high and a stab incision made, with the handle parallel to the body. This is extended by scissors, again held parallel to the body. Even though we have gone through the peritoneum, sometimes there seems to be a thin film over the abdominal contents. We just break this with our finger. I use the forceps to raise and deviate the muscle to the side. This helps me get under the abdominal contents. I touch the vertebrae and slide back up the muscle wall, using my finger as a hook to pull up the uterus. It always takes a while to get the knack of it and learn from touch which is the uterus. If you are ever unsure whether it is the uterus, check for an ovary or bifurcation. Push down to get the ovary with your left hand. Then transfer the ovary to your right hand. And while keeping tension on your ovary, slide down the suspensory, right to its insertion at the last rib. Then just push down to break it. There are two ligaments, suspensory and renal. Don't break the renal. You can tell which is the renal as it goes straight to the kidney. The suspensory goes round the back of the kidney. We keep the renal, as it protects the ovarian vessels. Without it, any pulling on the ovary puts tension on the ovarian vessels, making it dangerous. You can see where we make the window, in the translucent area, away from the vessels. Try and make to windowder, otherwise we will not be able to push our millers down deep. Hold the ovary as you walk the clamp down, remove anything caught on it, and once in position 1 to 2 clicks. Now double clamp above the ovary and separate the uterus. Tie your millers below the clamp, keep it loose, nudge it down, rotate the clamp if possible, and tighten, add 4 to 6 ones. Keep the tails short so they don't get caught in the second millers. Then raise the clamp, while holding the ovary. Make sure the clamp clears the ovary, and then form, place, and tighten the second millers. Remove the clamps and check for bleeding. If unsure, replace clamp and ligate again. Once happy, remove the ovary and release the pedicle. Make your window in the translucent area of the broad ligament, clamp, and then tie off. But in this case, as it was completely non-vascular, It was torn instead of ligated. There are two benefits from this. It means less tissue is present when you tie off the uterus. It helps to exteriorize the other uterine horn more. So now repeat the process on this side. The suspensory tends to be twice as thick, or more, when compared to the right side. When you break it, keep the tension on the ovary, so the suspensory is taut, and push down at the insertion, or as close to it as possible. If this doesn't work, sometimes we'll go under the insertion with my finger and push upwards. You can see here, the push-up technique worked and broke the suspensory. So make the window in a safe position, away from the major vessels. Place the ovarian clamp, separate the uterus, add 1 millers, move the clamp up and add 2nd millers. Check for bleeding. If okay, remove the ovary and release the pedicle. The broad ligament window is made and the ligament torn as no blood vessels can be seen. As you can see, we have exposure of the uterine body. Do not use crush beds, as this will snap off the uterus in some dogs. First I apply a surgeon's, as this is least likely to cut through. The next is usually a transfixing, but I wanted to show you, it is okay just to place a 2nd millers. A clamp is placed across the uterus and cut so the crush bed is not in the dog. This is very important for Danish vets, not to leave the crush bed side in the dog. Check there is no bleeding and then push back in and check again. Occasionally there is no bleeding as the vessel is bent over the muscle, but once released starts bleeding. We are limited to the suture type we can use, being a charity. The muscle is closed with a simple interrupted pattern of catgut. Advantages of catgut are, it is easy to control tension and fantastic knot security. Ligatures are placed top and bottom, as easier to get to, if the muscle cut underruns the skin incision. Now for a continuous fat layer with PGA, start deep superficial on one side, and superficial deep on the other. Form the knot and first pass must be deep superficial to hide knot. I usually close with the surgeons, but wanted to demonstrate an Aberdeen. I always do about 6 passes and always pass through twice at the end, for better stability. To bury the knot, I pass deep in front of the needle and exit on the intradermal area. So to bury the knot, I pass it deep through the wound, just in front of the knot. If needle passage is easy, it indicates burial is possible. If doesn't glide through, I go again until it does. Put some tension on the suture, but you mainly want to bury the knot by using forceps. Pick up the skin with the forceps and push it towards and over the knot.